So I'll try and make this interactive. This has always the potential to be a bit of a dry subject, and I know you're not meant to dish your own talk before you've started, but so everybody just chip in. I try and make this as practical as possible. There is a need to have some background physiology and sort of understanding some of the science, and I'm no scientist, so I'll keep it simple. Do chip in if you think anything I'm saying is a load of nonsense. And we'll do time allowing this. Is that not working? I'll flick this, should this not? Yeah. There we go. Okay. So we'll try and get through this, and then we've got a few sort of little clinical cases at the end if we've got time. What's on? Whatever. We'll talk about a few basic concepts and definitions. We're going to focus on the carbonic acid bicarbonate buffer system because that's the one we use clinically, the one which our machines are based around and our interpretation is based around. But we will talk about the limitations of that. And if we get a chance, we'll go have a little chat about the sort of physical chemical Stewart's theory, which no one really uses at the bedside, and I don't fully understand, but we can talk a little bit about it. Obviously, we'll have a chat about the primary acid-base disturbances, a little bit around the compensatory mechanisms and some rules that we can apply to assess them, but we rarely do at the bedside in reality. We need to talk about the anion gap and osmolar gap for metabolic acidemias, and then we'll do a few practical scenarios if time allows. So what is, obviously going to pick on this really well, but what is the big deal about acid base? What are we actually talking about in essence? Anyone?
Maintaining physiological pH, you've said, pre-bias.
Yeah, so fundamentally, we're talking about hydrogen ion homeostasis, aren't we? We're kind of used to talking about glucose homeostasis or sodium homeostasis. But when we talk about pH, as I know you understand what the notation means, what we're actually talking about is acid base, is hydrogen ion concentration. So that's the fundamentals, and hydrogen ions are absolutely ubiquitous within our physiology. We're on a different scale of sort of moles here. We're down at nanomoles rather than millimoles. So pH of 7.4, as I'm sure you'll know, is 40 nanomoles. And we'll look at the scale because, of course, the pH scale is logarithmic, so it can be a bit misleading. The body can actually tolerate huge changes in hydrogen ion concentration in a way that you couldn't with potassium or sodium or calcium or chloride. So there's a huge system of sort of values that we can survive across. As a general rule, physiology tolerates acidemia better than it does alkalemia. So the extremes of pH are usually at the low end. We turn over about 150 millimoles per day. Most of it is around aerobic metabolism and the Krebs cycle. 90% being released from ATP hydrolysis, and most of it again is recaptured in the same process. So it's a big deal, and there's very few processes going on that don't involve hydrogen ions. I'd say probably virtually none. So we talk, because of these very small numbers, mathematically we talk about pH, which is the inverse log to the base 10 of the hydrogen ion concentration, which can be a little bit deceiving. And we'll have a look at that now. So we talked about why it's important. Every enzyme, every biochemical system is partly driven by pH. And of course, the pH determines the degree of ionization of proteins and of all elements in the body. But it's fundamentally important to physiology. So a few things to point out, and I know you know this, but we're sitting here at 7.4, 40 nanomoles. In terms of physiology and in medicine, I've seen patients with pHs of below 6.8, and the sort of examples I would think of would be DKA is a very good example, or post-cardiac arrest syndrome. So people with circulation, they probably wouldn't be fully conscious, but you're going from 40 nanomoles to over 160, so a fourfold increase in hydrogen ion concentration. The other thing you've got to remember is this is logarithmic. So the jump from 7.4 to 7.3 is 10 nanomoles. If you go from 7.3 to 7.2, it's 13, or 7.2, 7.1 is approaching 20, 7.1 to 7, it is 20. So each incremental pH unit change is a bigger change in terms of hydrogen ion concentration. I'm sure you gather that. I've never seen a living person with a pH of 7.8. Has anybody? It's the highest pH value anyone's seen. Alkalemias. They're much rarer, aren't they? You know, it's unusual. I think high altitude mountaineers, when they've got severe respiratory alkalosis, and their pHs can come down to below 1. I know there was a UCH years ago did an amazing bit of science with one of the Everest teams where they didn't put arterial lines in. I think they used capillary gases to look at what these mountaineers achieved high up, and their CO2 was 0.8 and their pHs of 7.7. They're all on carbonic anhydrase as well, which changes it all. But I think that I'm not sure I've ever seen a pH above 7.6. I mean, what would a neonate get with pyloric stenosis? And I think they can get quite alkalemic. But so I think the point of putting that up is just to see the logarithmic scale and the incremental changes as you go down the system. So a few definitions. Lucy, I'm going to pick on you now. What's an acid? And I'm not a chemist, so they don't need to be too clever. Can't hear you.
Proton donor?
Yeah, so an acid, in very simple chemical terms, is a moiety that will give up a proton or take up an electron. That's my memory of chemistry or A-level chemistry. A base is the opposite. So we'll accept a proton in reactions. What do we mean when we talk about strong and weak acids? What's the relevance of strong and weak acids?
Substance. Yeah.
Not unless they burn.
It's a strong associates.
It's all, yeah, we're going to come to it now with Henson acid. It's all about the degree in which they dissociate. Very strong acids have low pKa's, don't they? And they're highly dissociated, hydrochloric acid. Weaker acids like carbonic acid have higher pKa's and are less dissociated to the level of dissociation. You might come across these terms volatile or non-fixed and non-volatile or fixed acids physiologically. Any thoughts on what that means? I've not come across that.
Volatile acids is like the ketone acids, which we metabolize that could be volatile ones.
No, so my understanding is that volatile acids, it's really mainly carbonic anhydrase, and it's those acids that are related to CO2, so it can be expressed as CO2 from the lungs. So things like organic fixed acid would be like ketone lactates or acid coming from phosphate or sulfate substances. It's not a terribly useful concept, but the volatile acid for us is carbonic anhydrase, and it's mobilized through the relationship with the lungs. Is where the terminologies come from, is my grasp of it. And a buffer, when we talk about a buffer. Yeah, so a buffer is the conjugate base and its acid in solution that if there's a change in hydrogen ion concentration, by mass effect will limit the change in pH. So again, we'll come up to the carbonic anhydrase system in a second with them. I know you know very well. A few more pedantic clinical terminology. What's the difference between an acidosis and an acidemia?
By the pH of whole blood is.
Yeah, let's go over it. Yeah.
Acidosis is.
So an acidemia is a state, an acidosis is a process. So you can have a respiratory acidosis, which is the process of depressing a pH through CO2 retention. So that would be the acidosis. If your pH is below 7.36, you have an acidemia. So and the emia is obviously relating to the pH of the blood. And it's just nice to get those right. It's a bit like, I get a bit, not tense, I'm not that bothered, but people talk about hypoxia when there's a low PO2 and it's hypoxemia. It's exam fodder, but it's nice to get it right. Do we know the definitions we talk about on our base deficit or excess, which is the same thing, standard bicarbonate? What's the base deficit? When we talk about we're on the water and Aslam said, like, what's the gas? And he tells me for the base deficit's -7. What does that actually mean?
It means the amount of acid you can add, or you need to add to the blood to make it into a normal pH at a standard temperature coming down.
So it's the amount of acid titratable against that sample of what's effectively extracellular fluids that you would need to bring the pH back to 7.4 in the presence of a CO2 of 5.3 at normal temperature. So at a glance, what it tells you is the metabolic components of acid-base derangements. So what's the standard bicarbonate?
I think it's a compilation that they do within like or an algorithm that they use within the blood gas machine.
Yeah.
So I could put in like a certain temperature and certain.
It's just what the bicarbonate would be at a PCO2 of 5.3.
Yeah.
Okay. We don't talk about standard bicarbonate so much, but the base deficit, base excess is quite a useful concept. We don't use it quite a lot, don't we? So be familiar with those terms. So there we go. So that's the equation. Those equals, by the way, should be those moving arrows. They're not equal, obviously. That's the carbonic acid equation. CO2 and water to combine to form carbonic acid, and it will dissociate into one proton and a bicarbonate ion. And we know this is used because the kidneys have an effect this end with bicarbonate regeneration, absorption, CO2 excretion at this end. And carbonic acid exists pretty much everywhere, I think. It is, again, ubiquitous. And of course, this is driven and amplified by carbonic anhydrases. So it's not just a mass action effect that these equations move back and forth. We've got a specific enzyme driving this process. And it's intimately linked with metabolic CO2 production, CO2 excretion through the lungs, bicarbonate production in the kidneys. They're the fundamental physiological pushers and pullers of the equation. And we're using this single equation as our determinant of pH. And as you know, that's slightly oversimplistic. And we'll come back to that. So mathematically, you all know it from your exams. The Anderson-Hasselbalch equation will describe the relationship of the pH and the relative amounts of the conjugate base and acid related to the pKa of that particular weak acid to allow you to calculate the pH. So just for the sake of exam fodder, if we apply this equation to the carbonic acid system, pH pKa is the log 10 of the conjugate base, A minus over the acid HA. Plug in what we need for our Anderson-Hasselbalch. So the conjugate base is bicarbonate, the acid is H2CO3. The pKa of carbonic acid happens to be 6.1. So the pKa is the inverse log of the acid dissociation constant. And if memory serves me right, the lower the pKa is, the stronger the acid is, but also the pKa will equal the pH when that particular acid is 50% dissociated, 50% non-dissociated, and that's where it comes from. Carbonic acid is fundamentally determined by soluble PCO2. So we can change H2CO3 to the P little a CO2 and 0.225, which is the solubility coefficient of CO2 in kilopascals. Plug in the rest of the numbers, normal bicarbonate of 24 millimoles per litre, 5.3 PCO2, and out comes our pH of 7.4. So from that, you can see there are two variable determinants in this theory of acid base that will change things. It's either the CO2 or the bicarbonate. They're the two variable determinants when we're restricting ourselves to the carbonic acid system of looking at pH. Everybody happy with that?
Desire to do something.
Yes, yeah.
Do you actually?
Yeah.
Yeah.
Go to it. I'll supervise.
I'll supervise.
Oh, cool.
As we've alluded to, these two elements are renally and ventilatory dependent. I just quickly put this up. What's this called? Those of you in exam mode. This is essentially a graphical representation of the Anderson-Hasselbalch equation. So this is called the Davenport diagram, which is the kind of thing I think you'd still need to know for your exams. It's a rubbish projection, I apologise, but on the bottom you've got bicarbonate. Horizontal axis you've got bicarbonate. in millimoles. On the lower axis, you've got pH. And you've got these, you can draw in as many CO2 lines as you like. So we just got 3 here, 40 millimoles, 27 and 60. And this will allow you to determine the pH given a bicarbonate and CO2 graphically. So if you're in normality, you're here, you're on the PCO2 of 40 millimoles, 5.3 kilopascals, pH 7.4 and a bicarbonate of about 24, 25. And this used to be used at the bedside. You can see the 4 primary abnormalities of acid base. Bottom left, metabolic acidosis, where we have a falling bicarbonate and a lowering pH. And the primary process will occur on the same CO2 line. Metabolic alkalosis, less common in adult medicine, opposite, a raising bicarbonate. And along this line, we've got the respiratory changes. Respiratory acidosis going this way. Notice with the respiratory acidosis, you get a very slow increase in bicarb because the equation is being moved that way. Respiratory alkalosis the other way. And you can then draw in the direction of travel of the compensation. The respiratory compensation will further lower your bicarbonate but bring your pH closer back to normal as you move from 40 millimeters of mercury towards this 27 millimeter of mercury line. So it's essentially a graphical representation of Henderson-Hasselbalch and used to be a favourite of examiners. Worth just having a look at and perusing if it ever does come up. It's quite a useful thing to have a grasp on. So I keep talking about the fact with only going on about the bicarbonate system, we all know that, and this is the problem with this slightly oversimplistic system, we've got lots of other buffering systems, various phosphate systems. The plasmid proteins are enormously important. Hemoglobin also buffers, slightly different pKa's. You can see they're all going to have a slightly different effect on ionization. We'll come back to that. Just a little schematic really to reinforce this idea of the sort of parallel effects of the respiratory excretion of CO2, the renal excretion of bicarbonate, or more commonly regeneration of bicarbonate. Just as a matter of interest, at a normal pH with a pK of 6.1, most of carbonic acid exists in its base form, so dissociated rather than to a ratio of 20 to 1, rather than as in its acid components. Any questions, do shout out. Quick table, just to remind ourselves of the very basics of the primary changes versus the compensation mechanism, which we'll come back to. So metabolic acidosis, we see a fall in pH, we see an acidemia, we expect to see a drop in bicarbonate. The response to that is a drop in CO2, so a compensatory respiratory alkalosis. And remember, we never overcompensate. pH will move back, but it'll never reach 7.4 again. This is all fairly self-explanatory, so I won't go through it. I'm going to talk a little bit about the compensatory mechanisms and some of the rules in terms of how, if we wanted to check there weren't 2 primary processes going on, how we can do some calculations. The main thing when you look at a blood gas is determine the primary process. Is it primary metabolic or respiratory? Then have a think about how much compensation has occurred, and that will be determined by the nature of the primary process and also how much time has elapsed. Someone in chronic respiratory failure and chronic respiratory acidosis will have a greater metabolic compensation than someone in acute hypercapnic respiratory failure, for example. If you're concerned, but I can't remember, when was the last time anyone saw a clinician use the Boston rules at the bedside and actually do the calculations? Not in my memory. It's not often we do it, but I'll go through them in a minute. If the numbers don't add up, then you've got to presume there's a secondary process, like, I don't know, someone in sepsis, you've got a severe metabolic lactatemia, but they're also obtunded and they've got a primary respiratory acidosis as well, and the CO2 retaining. And these little clinical calculations will let you quantify that degree of lack of compensation. There are 6 rules. I don't honestly think you need to remember them. Some people call them the Boston rules, and they apply to the following scenarios. So in acute respiratory acidosis, so acute hypercapnic respiratory failure, if you recognise that as a primary process and you want to assess what the appropriate bicarbonate change should be metabolically, then for each bicarbonate concentration should increase by 1 millimole per litre for every 1.32 kilopascal rise above 5.3. And you can do that calculation quite quickly. In an acute respiratory acidosis, you see bicarbonate changing reasonably quickly. It's within hours to start seeing changes. So if that number doesn't work, you may have a secondary process going on. Like the example I just gave, if patients have tunded, they may actually have a primary respiratory process going on as well. So that's rule 1 for acute respiratory acidosis. So for chronic respiratory, you're going to guess there's a greater change. You actually have an increase of a 4-fold change. And I've made the comment here, kidneys retains bicarbonates. Over a number of days, you'll see this 4-fold greater compensation process going on in a chronic situation. Acute respiratory alkalosis, hyperventilation, there aren't many examples, are there, of acute respiratory alkalosis. The bicarbonate should decrease by 2 millimoles for every 1.32 fall in CO2 tension below 5.3 in acute setting. And you'll see a change, but it rarely exceeds in a bicarbonate fall below about 18. So there's a limited metabolic compensation to acute respiratory alkalosis. There's a limit to what the kidney is going to do in that situation. In a chronic respiratory alkalosis, what clinical examples do you think of chronic respiratory alkalosis? Must be some drug-driven ones, but
Generalized anxiety.
Generalized panic, yeah.
Setting the ventilator wrong.
Sorry,
Setting the ventilator wrong.
setting the ventilator wrong, absolutely. That is the cause, isn't it? That's the cause. And we see a 5 millimole rule change. You get the gist of this. More useful for us, metabolic acidosis, and looking for what the appropriate respiratory compensation is. That's the equation. The expected CO2 should be 0.2 times the bicarbonate change plus 1. I've never sat down and validated these. I'm not quite sure the science behind them. Comments being max compensation is in the first 12 to 24 hours, and you'll very rarely see someone get their CO2 below about 1.3. I see low CO2s than that, actually in DKA. And then the final one is metabolic alkalosis. And again, simple calculation to work out what you should be looking at. So if you're looking at complex blood gas, I think these things are worth going to occasionally, just to sort of work out if the compensatory change is what you think it should be. Any queries or questions on that? Anyone think I've got that horribly wrong? Happy in Glenfield?
Yeah.
So we do a little bit more than just look at the bicarbonate system. But just look at the bicarbonate system. There's a couple of other things we need to understand and know that can cause particularly metabolic changes. And one, of course, is the anion gap. So again, a random person in the room, what's the anion gap?
It's a sodium minus the chloride bicarbonate.
Close. It's the main measure. You could just take sodium because that's the predominant.
People usually do.
They do. Exam answer is going to be sodium potassium minus chloride plus bicarbonate. So what's the concept behind it? What are we on about?
Essentially, in the body, you've got measured anions and unmeasured anions, and so on and so forth with cations as well. And so what you're trying to measure is there a gap because of the unmeasured anions or not causing your metabolic acidosis.
So there may be an unmeasured acid that's released anions that we're not taking into account with our normal using ease measurements, and we see a gap.
Yeah.
And it can lead us to potentially a different diagnosis. So it's the estimated unmeasured, and they might be endogenous or exogenous. So lactate and ketones are the obvious endogenous ones. Because we don't include all of the free acids, so we don't take into account proteins. We don't, in our normal calculations, there is a normal gap of 12 to 18 millimoles of negatively charged moieties that we don't calculate. And lactate is one of those, up to a value of whatever your machine says, 2 or so. And anion gap acidosis is due to acid producing unmeasured anions. So that's the but I agree. That's you could ignore. And the thinking is if it's significantly in excess of 18, then you might be looking at an anion gap acidosis. If in a normal anion gap acidosis, the presumption is you are losing bicarbonate somewhere, whereas in an anion gap acidosis, an unmeasured acid is buffering the bicarbonate. You're seeing a fall in bicarbonate secondary to a new acid in the system. So this is sort of a pictorial picture of the normal situation. We've got some unmeasured cations that we don't think about too much, like magnesium, calcium. Sodium is the big contributor in extracellular fluids to our cation effect. On the other side, we've got chloride and bicarbonate. And then we've got some other cations we don't normally bother measuring and talking about. So they make up the 12 to 18 gap. And that shouldn't be any bigger than that. If it's significantly bigger, we see this portion, we see a fall in bicarbonate. And when we do our calculation, we have this high anion gap metabolic acidosis. Fairly straightforward concept, I think, but an important one to think about at the bedside. So what examples? I'll give you a couple already. So endogenous, obvious examples of an anion gap acidosis that we see regularly would be ketoacidosis, lactic acidosis. Any others?
Uremic.
Yeah, uremic acidosis, so renal failure, yeah.
So you got methanol.
You've got all the exogenous ones, haven't you?
Yeah.
So think of it as alcohols, sugars, and certain drugs, salicylates. You've got that big list of examples you've got to think of. So anion gap, you can break it down into these. So overproduction of acid, DKA, lactic acidosis, and some people break lactic acidosis into sort of type A, where you have a mismatch of DO2 and VO2, and a failure of respiratory oxidation and increased lactate production from glycolysis. Or type B, where actually you've got a normal cardiac output, but you've got some tissue, some that's ischemic, like your gut. Liver failure, drugs like metformin, biochemically might cause a lactic acidosis, and starvation lactic acidosis as well. And there's a long list of drugs, but the important ones that we see, and we get them here every so often, are the alcohol misuse, so ethylene glycol, antifreeze type stuff. And renal failure is another example with severe uremia. I put this in, but I don't like it. It's one of these mnemonics. I don't really get them. Just smart is quite a good one, I suppose. Ketoacidosis, uremia, salicylate, methanol, aldehyde, lactate, ethylene glycol. So when we talk about normal anion gap acidoses and we think about actual bicarbonate loss from the body, or there's some form of additional acid being put into the system, which won't contribute to an anion gap increase. So the really common bicarbonate losses you can think of as extrarenal. So gut losses are one of the commonest. We don't see many of these here, but you guys in Glenfield will now. Biliary pancreatic fistulas when bicarbonate is lost. Ileostomies, the classic uterosigmoid ostomy, or urinary diversion type procedures with chloride loss, and then the renal tuber acidosis and drugs like carbonic anhydrase. Normal saline is slightly controversial because, of course, that's a hypochloremic acidosis, and actually the bicarbonate system doesn't really explain that terribly well. But other excess acids containing chloride would give you a non-anion gap acidosis as calculated, if that makes sense. Everybody moderately happy with that? It's the same thing, that we call it the osmolar gap. It's still a kind of gap, but it's not an anion gap. So ethylene glycol will give you an osmolar gap as well as an anion gap. So it will suck up a load of bicarbonate, but it isn't truly an anion. And we can measure it through the osmolar gap. So it's a similar concept. So it estimates the unmeasured or unrecognized osmotically active molecules within the plasma. So there's the presence of an abnormal solute in the plasma that you're not normally measuring. So what you've got to do is calculate osmolality on the ward, which is just your main. Most people just do 2 times sodium, glucose, and urea. And then you send samples to the lab, and it's usually through depression of freezing point. They will work out if there's an abnormal osmol presence in the ECF. You can be caught out slightly by these severe hypoglycemia, hyperlipidemia, hyperproteinemias. You will have an apparent osmotic gap, but it won't be contributing to acid-base disturbance. So just occasionally you can be thrown. If you do someone with a blood sugar of 40, you'll find an osmotic gap because of the amount of solute from the abnormally high glucose. What you're trying to exclude are these things: ethanol, methanol, ethylene glycol, barialdehyde, which obviously, if you haven't in the history, might be difficult to pick up from a standard blood gas, and treatment per se could be, time critical. Again, I think, whenever you look at a gas, particularly metabolic acidemias, do think about the anion gap and the osmotic gap. Everyone okay with that? Is anything you've heard so far that doesn't ring true? Good. I just want to go very slightly off-piste. The carbonic acid system doesn't tell us the whole story. We've been alluding to this for some time. So it is not new. The Stewart theory has been around a long time. I think I'll see on the next slide, around 1983. He was a physical chemist who got into this. And there's a few things that we ignore in the carbonic acid system. One is we ignore end up with people who are chronically total body water restricted. Yeah, it's classic hypovolemic alkalosis, which is essentially aldosteronism, is what you see. You don't see that in acute hypovolemic patients, but with the breadwinners, do I need to log off, do you think, and try and log back in?
I think it's just based on connection there. Once you reconnect, it should be back on. I don't know if your internet is back. Yeah. So if it's there is working. Yes. Yeah. So I think they are still. Yeah, that's fine. Yeah.
Can you hear the Glenfield guys? Someone just shout.
I can hear you.
Right,
Yeah,
sorry about that.
Yeah, we're here.
So, yeah, total body water we ignore. We also ignore the presence of plasma proteins and other electrolytes that can act as buffers within, within physiological solutions. Other non-bicarbonate buffer system, phosphates, sulfate systems. And what we find, therefore, we can't always explain acidemias and acid-base disturbances perfectly, and hypothermic acidosis is the much talked about one. So he sat down and sort of tried to bring these other elements in and talks about dependent and independent variables. And one of the main features of this is the need for electrical neutrality across the physiology. You can't be more negative than positive. The dependent markers in this are basically PCO2 and bicarbonate. The independent things we'll come to in a second. And he describes three independent variables: a strong ion difference, which is nothing to do really, it's not the same as an anion gap, but he's taking into account many more active ions within physiology that can affect pH across the whole system. And basically, a dropping strong ion difference gives you an alkalosis, an increasing strong ion difference gives you an acidosis. And it's losses of some of these elements that we wouldn't normally look at. Did I get the wrong way around? Sorry. Decreased SID leads to acidosis. He then calculates something called the total weak acid concentration, which looks at all the impact of proteins. It's predominantly albumin in the equations, as I understand it. Albumin concentration, you factor that in, and then it includes CO2 as well in the equation. So it's more of a whole physico-chemical approach of pH analysis. The problem with it is it doesn't really work at the bedside. It is too complicated. Has anyone tried to use it, clinically? You ever dabbled with it as well?
The difference between sodium and chloride.
Yeah,
If you exclude everything, it sort of gives an idea whether it's.
it does. And I think of all the concepts, if you want to read a little bit more, the strong iron difference is probably the more useful of the three components. We take CO2 into account anyway. The working out the total acid concentration for us probably is less relevant. But someone who's grossly hypoalbuminemic, it will have an effect on pH. So just if you're ever looking at a very puzzling gas and they've got a very low albumin, that might be contributing. But I think the construct, if you're going to go away and do any little bit of extra reading, and it could come up in the exam, is the strong iron difference. And it brings in the effect of chloride in particular, where we can get into bother with. I don't want to keep going on about this. So what have I said here? So acid-base disorders, yeah, respiratory from a CO2, SID changes, which is to do with either water volume change or changes in the strong iron difference, and then changes in the proteins and other inorganic buffering systems like phosphate. So just, what are we with time, 22? Just a quick approach, and then we'll just do a couple of simple clinical vignettes to finish off with. One of my things is a blood gas isn't a diagnosis. One of the things that winds me up is, and we always pick on ED, sorry, but you'll get a referral. It's actually you've been referred a blood gas, not a patient. And a blood gas is an incredible, it's the desert island disc sort of investigation. If you could have one investigation for an acutely unwell patient, it'd be a modern blood gas machine, wouldn't it? With the hematinics, the gases, the pHs, the electrolytes. I'm not saying it's not important, but always keep it in clinical context with a history and examination and a working differential diagnosis before you start reading the blood gas. To make the most of the blood gas, you want all of these results as well, ideally, and the modern blood gas machines give us most of those, not clotting, not LFTs, but you'll get a lot of information from the modern blood gas machine. Start by just deciding what the primary process is. Is it an acidemia? Is it an alkalemia? By looking at those parameters. Base excess gives you the metabolic component. And then have a think about, is there likely to be any secondary compensatory processes going on? And again, think about the Davenport diagram and think about those secondary compensatory rules. If it isn't bold or obvious what's happening. On a really sort of pragmatic, almost Mickey Mouse, if you just do those four things with each blood gas, what is the pH? Is it an acidemia or alkalemia? What's the primary process? Work that out from the bicarbonate, the base excess, and the CO2, and have a think about the anion gap. I should really add the osmolar gap onto that as well. So 5 things should, under most circumstances, get you to an intelligent interpretation. Stick that in with your history and your other results. You should be sort of getting to some kind of meaningful conclusion. I regret this bit, but all the acid-base disorders can be put into these categories. So divide metabolic into normal anion gap and raised anion gap. The rare metabolic alkaloses that we see, people talk about them in chloride responsive or unresponsive. We'll come back to that in a second. And the respiratory acidosis or alkalosis. Those are really all the things you can think about. Calculate the anion gap, the osmolar gap. And if it's over 20 for the anion gap, think about anion gap acidosis. Look at your serum, ketones, and lactates and toxicology history. I'm not big on this. In terms of the chloride responsive or unresponsive, you need to look at your urinary chloride. And if the urine is depleted chloride, they're probably going to be chloride responsive. So upper GI losses would be an example of that, where you could start to correct an acidosis with chloride. They talk about pre-renal causes here, so renal hypoperfusion, gut losses, or diuretics would be examples of that. I don't think it's something we use a lot at the bedside, the chloride response concept. You need to send the urinary sample off to make sense of that. If it's over 20, then they're probably not chloride deficient and it's other diagnoses. So yeah, diagnosis, not treatment. So any thoughts? Probably the take-home slide, and I know you guys know this, but is that plus number 5 osmolar gap and the approach to the history. Really my message. I've just got 3. They're very simple, but just to sort of put the whole thing to the test. So we've got an elderly man who's developed diffuse diarrhea following a course of antibiotics for a chest infection. He's thirsty, lightheaded. Shortly after admission, the blood tests are as follows. So what are people thinking? Glenfield, why don't we throw this one at you guys? What, if you go through those 4 questions, what's the pH doing? God, it's a shoo-in. Hello, hello. Can you hear me?
Yeah,
Yeah.
Who wants to?
patient's acidemic.
Brilliant.
Their bicarb's a bit low,
Yeah.
which makes you think it's metabolic. He's got CO2 of 4.2, and I can't remember the relevant Boston rule as to whether that's an appropriate amount of
No.
CO2.
But you're going to say it's lower than it should be, so it might be consistent with a secondary compensation.
Yeah.
Yeah. Okay. Anything else?
So the chloride.
Yeah.
Oh, anion gap. God.
Grab a phone. Speak to yourself.
Just doing some maths. Sorry.
All right. It's normal, isn't it?
16.
Yeah, it's normal.
There we go. Yeah.
So what's the acid-base disturbance in a nutshell?
It's got a normal anion gap, metabolic acidosis.
Yeah. So you've got a normal anion gap, metabolic acidosis with probably appropriate respiratory compensation. He's got slightly depressed chloride. We don't do total CO2, but we agree to CO2 slightly low, and he's got some degree of renal impairment and raised urea. So with that history, what do you think the cause is? And what are we going to do?
GI losses, probably.
Yeah, absolutely. So bicarbonate GI losses. So management's going to be fluid replacement, and you could give some bicarbonate in that fluid replacement and manage his diarrhea. So a fairly easy example of a normal anion gap, metabolic acidosis with appropriate CO2 compensation. Super duper. So in the room with me, a 25-year-old mechanic is admitted very confused and drowsy. Initial laboratory results are as below. So guys, what do we think? Here.
So he's acidemic.
Severely acidemic.
He's compensating respiratory wise because his PCO2 is low.
Yeah.
Bicarb's very low.
Catastrophically low.
Yeah, you might want to do something about that. Lactate's normal.
Lactate's normal, ketones are normal.
So it's the metabolic acidosis
Okay.
that's been compensated.
So we've got some U's and E's.
So anion gap wise, 140. Oh god. The raised anion gap.
It's very raised. I think
it must be.
if memory serves me right, it's nearly 40. What do we want to do next?
Basically, yeah, is it like a antifreeze poisoning?
You want to know the Oswald gap, don't you?
Okay, you want
The last one's honestly.
You want to know the Oswald gap. And absolutely, there's a raised Oswald gap. And this guy's got bored in between his St. Carl's and Nexon antifreeze. And so you'd send that then for toxicology management.
Just to add here, it's very useful to look at the lactate gap. Because remember, we had a patient with an elevated lactate gap.
Yes.
The point of care machine is given. They measure by lactate oxidase method. So they also measure the metabolites of the glycol. So you get a very high lactate in your ABG machine. The slightly lower one, I set it off to the
Okay.
same time.
Yeah. Yeah.
And lactate gap it's
That's almost diagnostic. Yeah, that's great. Yeah, fantastic, Osman. Obviously, these are sort of a medical emergency, isn't it? And what would our management choice be? Omeprazole now, isn't it? I mean, it used to be alcohol. So it's the byproducts of alcohol dehydrogenase metabolism, isn't it? That's lethal. So in the old days, I can't remember the regime now, it's 10% alcohol at a certain mils per kilo of alcohol dehydrogenase until you've had enough, but flumiprazole is a direct acting alcohol dehydrogenase. HD as well is effective if you can get HD. I don't think filtration is as effective, so if you're going to use renal replacement therapy, hemodialysis would be an option of choice. Do we keep flumiprazole up here, Sarah? Or do we
Right, it's regionally kept, so you have to contact pharmacy.
Really? It's not even in the trust?
Not always, no, like some
That'll be useful.
There must be some in ED, yeah.
ED would be the place that keeps it,
Yeah.
but I think the last patient they had to get something to know.
Right. Oh, that's interesting.
How do you calculate the osmolar gap if they're co-ingested alcohol? Do you include that?
It would, so you'd have to have toxicology. So the measured osmolar gap is a depression of freezing point. So all the unmeasured osmoles will have an effect. So if he's had alcohol plus ethylene glycol, then yeah. But because alcohol wouldn't give you that sort of metabolic derangement. But yeah, you can't, you'd have to get toxicology then later to look at all the different substances. But good question. And finally, and I think I've given the answer to this one away earlier actually. So this is a lady who's been on CCU, been treated with diuretics for ages, and presents with these gases. What are we thinking?
So she's alkalotic,
Yeah.
respiratory compensation with carbon monoxide going up, bicarb's gone pretty high up as well. Otherwise, potassium's a bit low, might be on the diuretic.
That's the clue. She's on diuretic.
So
You see this in little old ladies on and off wards and things. So this is what we alluded to earlier, where again, classic bicarbonate acid base, you wouldn't get an easy answer. But she's been chronically water deplete, so total body water deplete, and she's got a chronic metabolic alkalemia with a degree of respiratory compensation. So you wouldn't necessarily do a great deal about it. Super. That, I think, is all from me. So, I mean, what I've hopefully done is kept a simple bedside approach, and I think that's the key, particularly out of hours with the key cases, keeping yourself to those 5 questions, which I think most of the time will give you the answers. Bear in mind the compensatory calculations in more difficult acid-base disturbances and the sort of caveats that we have with bicarbonate-based calculations and the presence of these other concepts. And I think SID is the one to think about, which you can use at the bedside. Good, good. Any questions or comments? Anything anyone else? With this talk coming around, well, it should have been maybe 6 months, been about a year since I've done it. Any comments from anybody that you want added, topics, anything we've not covered adequately?
Nice question. So
Yeah.
is that the principal way that diuretics cause alkalosis from total body water depletion, or is there any other way?
I mean, hypokalemia, so that will cause a degree of alkalosis, but it is water depletion, yeah.
And how long does that process take? Can that happen quite quickly? Can you get that?
Not acutely. I think over days to weeks with a contracted circulating volume. It's an aldosterone-based mechanism.
Oh, okay. So
it takes time, yeah. But hypokalemia is associated with alkalosis as well.
I think sometimes you see it on the unit when we start patients on diuretics, and then you get a bit of alkalosis as well in patients.
Well,
it does happen. The patient's hyperchloremic. How do you treat hyperchloremia? What do you?
Are we on
chlorine starvation. So you can only, in the presence of normal renal function, you try and chloride restrict to avoid chloride-containing fluids, because the commonest cause of hypothermia in hospital is normal saline by a country mile. So it's just chloride restriction and replacement with non-chloride-containing fluids would be my approach. Any questions from Glenfield? Comments, thoughts?
No, thanks.
If there's any other topics you want adding to this talk or anything you think would be useful, I think maybe doing some more clinical cases might be more useful to sort of test the theory out or the practice out. But yeah, good. Okay. If there's no questions from your end, Nick, are you? almost.
Yeah.
I think clinical cases always go down well, Gareth.
Yeah.
Just get started.
Yeah.
So the study I'll be presenting is entitled Therapeutic Hypothermia in Patients After a Cardiac Arrest. It was a systematic review and meta-analysis of RCTs. It was published this year in the American Journal of Emergency Medicine. The objectives of the study were to assess whether therapeutic hypothermia was associated with improved survival and neurological outcomes after a cardiac arrest. So just a bit of background on this topic. So essentially in the early 2000s, there were a number of trials which found that therapeutic hypothermia, so actively calling patients with a ROSC following an out-of-hospital cardiac arrest, improved neurological outcomes. The pathophysiology behind this is that calling is thought to reduce the cerebral metabolic rates. It's also meant to reduce glutamate production and also reduce oxidative stress free radical production, hence improve neurological outcomes as a result. So around this time, many centres were therefore actively calling patients for at least 24 hours, and this was around 32 to 33 degrees Celsius. And this was done by a variety of methods. So external calling methods, so just ice packs to the skin, for example. But later on, internal calling devices were introduced. So we're talking intravenous or intravascular catheters with infusions of cold fluid. Interestingly, more recent landmark trials, so TTM1 and TTM2, found that there was actually no difference in neurological outcomes between actively calling patients to this 33-degree mark versus normothermia, essentially preventing pyrexia, so stopping patients getting temperatures of above 37.7. And in fact, that reflects ALS guidance, which suggests in patients with a ROSC following an out-of-hospital cardiac arrest, we're to prevent pyrexia for the first 72 hours. It's also worth mentioning that therapeutic hypothermia, so calling patients, does come with complications. So the complications that this study looks at in particular are bleeding, arrhythmia, and pneumonia, but there's also issues with hemodynamic instability, and also excessive shivering, which may increase sedation requirements, and also many patients need to be paralysed, which can contribute to critical illness markedly.
Got a hand up. It's also a question.
Are there slides that should be moving?
No, sorry.
Oh, okay. All right. My bad.
Can you see them move?
Yeah, perfect. Sorry.
Yeah. Do you need me to repeat any of that?
No, we heard it all. Yeah, thanks.
So coming back to the trial, methods-wise, it was a search of online databases, some of the definitions and the characteristics of the population they're looking for. So therapeutic hypothermia, I'll just refer to it as TH here, was defined as actively calling patients to 32 to 34 degrees. Normothermia was achieving temperatures of 36 to 37.7 degrees. The population studied were adults who remained unresponsive after a cardiac arrest, and now this includes both in-hospital and out-of-hospital cardiac arrests, albeit the more recent RCTs looked into out-of-hospital cardiac arrests. The outcomes that were being assessed were neurological disability, and the most common score is the modified Rankin scale, but also there was a cerebral performance category that was used, and also the secondary outcome was mortality. A subgroup analysis was done by the study, so they looked at patients' initial rhythms following a cardiac arrest, the initiation of therapeutic hypothermia, be it early versus late, so within 2 hours, and the duration of TH as well, so greater than 24 hours.
So you probably said it, Nick, sorry. Were they looking at the instigation from cardiac arrest to how quickly therapeutic hypothermia was?
Yeah. If therapeutic hypothermia was started before the 2 hour mark, that was deemed as quick.
Okay.
Anything above was slow.
And none of this was pre-hospital?
I need to double check the trial actually.
Okay. Is that an old hand up or is that a legacy hand?
I think that was old.
Gold. And the study also looked at adverse event rates. So the study only looked at bleeding, pneumonia, and arrhythmias as complications from either normothermia or therapeutic hypothermia. So the results of the trial, so 9 RCTs were eventually included with 4,000 patients. And essentially one of the take homes is there's actually no difference in mortality in therapeutic hypothermia versus normothermia. There was however one positive finding. So as a result of the subgroup analysis, the authors found that neurological prognosis was better in patients who had an initial shockable rhythm, and that neurological prognosis was even better still if therapeutic hypothermia was started within 2 hours and lasted for more than 24 hours. So the risk ratio of TH versus normothermia in that case was 0.87, and as you can see, the confidence intervals almost go up to 1 with a significant value. With regards to complications, so the observed rates of adverse events from either hypothermia or normothermia, there was actually no observable difference. The p-value is in the results as well. I included some of the forest plots here, but they're probably a bit of a muchness. The conclusion from the study was that therapeutic hypothermia has potential neurological benefits for patients with an initial shockable rhythm after a cardiac arrest, or actually faster therapeutic hypothermia initial duration. So I have this slide is essentially just my thoughts from the CASP checklist. So I just kind of kept things short for you. But in essence, the issue with the study is that so we had 9 RCTs that were included. There was only 2 RCTs that actually had favourable outcomes of therapeutic hypothermia, and these were both conducted in 2002. These studies, although they were included in the analysis, actually demonstrated significant heterogeneity and bias. So one of the studies wasn't randomised and provided no information on patient comorbidities. And these studies also did not describe how normothermia was maintained, as in whether the patients had active fever avoidance, which is what we do now, essentially by giving antipyretics, for example, I'm calling. Also, these earlier studies only had the advent of external cooling rather than internal cooling devices, which were more commonly used towards the back end of therapeutic hypothermia and in vogue adoption. And also as well, with the studies being so far apart in terms of time when they're conducted, there's actually been a 30% improvement in all-cause mortality in cardiac arrest. So having studied in 2002 to 2022, there's so much more that we're doing for these patients that could actually improve their neurological outcomes and mortality. Another few things just based on this slide are that doing subgroup analyses on RCTs that weren't powered for that initial question is problematic. This is a very hard thing to blind, therapeutic hypothermia. Follow-up was at maximum done at 6 months in most studies, so no longer. And actually the time to initiation of TH, which is one of the author's conclusions that showed improved neurological outcomes, that just might mean that patients had an early return of ROSC and therefore improved outcomes. So my bottom line is that actually this paper is only hypothesis generating, and that more research needs to be looked into psychotherapeutic hypothermia and improve outcomes in relation to a shockable rhythm versus non-shock element. And that's the end of my presentation.
I think for me, if it like it's the heterogeneity of this population, isn't it? Because cardiac arrest, again, it's kind of a diagnosis, but you arrest for a reason.
Yeah.
So if you have a VF arrest that demands, and it's a coronary artery occlusion, and you get PCI, then the outcomes would be far better. Now, I don't know if those sorts of patients were excluded from this, if they had another primary intervention other than being admitted to ICU and were offered hypothermia, if there was a definitive management, and the obvious one would be PCI. And then the range of comorbidities, which I know they would have risk stratified for to some degree, but it's very difficult, isn't it? And then did they define the levels of hypothermia? Because certainly the old school of the 32 degrees, I think we binned a long time ago. Then we had sort of mild therapeutic hypothermia, and then we went to TTM, so temperature targeted management, which is essentially avoiding pyrexias, and that's kind of where we are now. But yeah, it's going to be very difficult to interpret, isn't it, for those reasons? And I think there were trials, which is why I asked, the pre-hospital cooling of unconscious patients. So because a lot of this has come out of anecdotal pre-hospital medicine of people, arresting from in cold environments to neurologically. And I think there were some trials looking at pre-hospital cooling, quite how they did it, but so the timing of the cooling is the next really difficult bit, isn't it? So in essence, that's left us at just TTM, hasn't it, really? Yeah.
Did they look at the differences in outcome in hospital and principal arrests?
So that wasn't a subgroup analysis. No, they included all of them.
So this was a mixture of in and out.
Yeah, exactly.
Yeah, so they do a subgroup analysis of that's another thing, because the outcomes are going to be quite different.
So I think there was only 2 trials which looked at, 2 trials that made it into this analysis, which looked at in-hospital cardiac arrest, but they were all bundled together. And that the groups are different in culture.
Yeah, no, the outcomes are very different. Yeah.